I'll kick us off again. This is a panel discussion on exploring comorbidities of PTSD, depression, and substance use disorder. I'll be the moderator for this discussion. I'm Trey Andrews. I'm an associate professor at the University of Nebraska-Lincoln. We've got a great set of panelists here today. Before we get to them, I do just want to give some reminders and updates. This is in the chat. But the chat function is disabled for this panel, but we do want your participation. So please do send those questions that you have just using the Q&A function. I will be monitoring that even as our panelists are discussing throughout the day today. And we really want to make sure that we prioritize your questions and that we have some good interaction with you and our panelists today. So please do use that. Again, the chat won't be enabled. You won't be able to use that to ask questions and use the Q&A function. With that in mind, again, I'm Trey Andrews from University of Nebraska-Lincoln, and I will let our panelists introduce themselves, where they're coming from, the institution, their role at that institution, and maybe a little bit about their areas of expertise. And I'm just going to go around and I'll call on each of you. I'll go on the order that you are on my screen. So Christy, Dr. Capone, could you introduce yourself?
Sure. Happy to be here. Hi, everyone. I'm Christy Capone. I am a clinical psychologist. I spend most of my time at the VA here in Providence, Rhode Island. My role there is I'm what's called PTSD SUD specialist. So I work with veterans that have co-occurring PTSD and substance use disorders. I'm also assistant professor in psychiatry and human behavior at Brown, and I do research in the same area. My clinical work and my research are very much linked, and I do treatment outcomes research, and that has sort of taken me down the road to looking at alternative treatments for comorbid PTSD and substance use, including some psychedelic work that I'm involved in now regarding MDMA. So I will stop there. Happy to be here.
All right. Thank you, Dr. Capone. All right. Dr. Monti.
Yeah, good morning, everyone. My name is Peter Monti. I am a professor of psychiatry and human behavior, as well as behavioral and social science here at Brown University, where I have been for several decades. My focus is clinical research. I'm trained as a clinical psychologist. But I've spent a lot of my time in administration and administering clinical treatment programs, as well as clinical research programs. Currently, I'm principal investigator on a COBRI grant, the focus of which is looking at the role of substance use in the area of chronic disease. That's a COBRI grant that is equally sort of focused on bringing along the next generation of scientists who are interested in substance use and chronic disease, as well as furthering the science of the role of substance use in chronic disease. The other major activity that I'm involved in is that of training postdoctoral fellows. I'm principal investigator of an NIAAA T32 grant that it's now in its 45th year. I haven't been PI of it in the entirety, but for the last 30 years I have been. And there we focus people to do treatment outcome research. So my area of research concentration is alcohol and HIV, both from a biological as well as a psychosocial perspective. I'll stop there.
All right, thank you. Dr. Acosta.
Hi, everyone. My name is Dr. Laura Costa. So I'm currently a child and adolescent postdoctoral fellow at Nicklaus Children's Hospital here in Miami, Florida. My research focuses on mental health disparities broadly, with an emphasis on also understanding mechanisms that contribute to inequities that we see in substance use and treatment engagement among underserved communities. I use ecological momentary assessments, so EMA, and other technology-based tools to capture how stress, affect, and craving interact in daily life to shape substance use behavior and to examine how these real-time processes also influence perceptions of treatment effectiveness and help seeking. Yeah, my doctoral work at the University of Nebraska-Lincoln, funded by NIDA F31 fellowship, did indeed center on identifying like momentary pathways to improve prevention and intervention efforts for substance use. So happy to be here.
Yeah, thank you. And it's a lot of fun. I think that's the first time I've gotten to officially introduce you as Dr. Acosta. She's a mentee of mine here at Nebraska. It's great to see you moving on. All right, we'll move on to our final panelist, Dr. Bauer.
Hi. Thank you for having me, and I'm very happy to be here, so much my co-panelists. I'm Alexandria Bauer. I'm an assistant professor at Rutgers in the Graduate School of Applied and Professional Psychology, and in the Center of Alcohol and Substance Use Studies. So I'm in clinical psychology by training, but I'm primarily focused more on research and teaching. And my research interests, I will say, are really centered on promoting mental health outcomes and capacity across communities, especially using community-based participatory research methods. So really focused on involving stakeholders and community members, people with lived experiences as part of our work throughout the process. And really focused right now on trauma, substance use, especially prevention and early intervention, and also promotion of mental health literacy. So knowledge and awareness of mental health, so substance use symptoms, and how to manage or cope with some of the symptoms as they come up for people.
All right. Thanks, everybody. And again, welcome. We'll go ahead and dive into some of our prepared questions for the panelists. But again, just reminding the audience, please do submit your questions for our experts today using the Q&A function. I'll be monitoring it throughout and reading through some of the questions. It may go a little bit out of order, so if it takes a little bit to get to your question, don't worry. We're just trying to make sure it all flows together nicely, at least as best we can. So we're going to start off with a question about what are the primary factors that you see contributing to individuals accessing treatment for PTSD, depression, and substance use disorder? And can you talk about what factors also contribute to success in those treatment outcomes? And we'll open this up for the full panel.
I can just share to get us started that it has been interesting to me to see over the years that I think people often are more willing to come in and address trauma in some ways rather than substance use. There's, I think, still very much a stigma related to substance use, and people don't like to be labeled as having a substance use disorder. So I have found that in some ways it's easier to engage them on the trauma side of things, and then often when I introduce myself and my role in the VA, and I sort of just normalize how common it is that substance use goes along with PTSD, people instantly seem to kind of relax and say like, yes, that's me. So that is just one of the, I also think, and we probably all know this, that oftentimes what gets people in the door to seeking any sort of help is at the urging of other people. If there's someone else in their life that's really kind of encouraging or pushing them, or there's some, unfortunate consequence that has happened that sort of leads them at least to be willing to seek treatment. Those are my initial thoughts.
So in support of Dr. Capone's analysis from a clinical perspective, I think the research literature really supports the role of stigma in interfering with people's ability or access to treatment and motivation to seek it. So I think there's strong support for that, both from a clinical perspective as well as from a clinical research perspective.
Yeah, echoing what Dr. Monti and Dr. Capone were saying as well. It really depends on just like the person's awareness of like their symptoms and like the severity of it. I found the same thing in clinical practice. Most folks that are coming in and they're willingly saying, I have a like an issue with like drugs, it's already like really far in advance. Like they are either, they maybe got a DUI or they had a like a family like drift apart. Like it's already, so I think it's like having a timely like engagement with treatment is also particularly important, but that's also really hard when there's stigma involved, right? And then there's lack of availability. Some folks have an image in their head that the only way they can, get treated for substance use is if they go to an inpatient like Zen spa. And I'm like, most people cannot afford that.
And I think one of the things that I have seen, at least in persisting kind of with that stigma, some of the work that I've done specifically with young adults who were identified as Black or African American, although I think this persists across different types of cultural groups and communities, is that they were saying that there is less stigma than previous generations, so younger generations being more open to seeking support and treatment. But at the same time, kind of the feeling that I would seek support, but I wouldn't necessarily tell people about it. And so I think there's kind of the role of I'm willing to address it. I'm willing to acknowledge that maybe I do have challenges with substance use or I could use some mental health support. But I think not knowing who else is kind of going through the same things or the same experiences can kind of prolong the stigma if we're all assuming that everybody else is, functioning and not having any of the same experiences. I think for many people, not knowing, as Dr. Capone said, how common it is, and often how much there is maybe a hesitancy about how do I address it, what to expect, when I do seek support. And so I think, as Dr. Costa said, knowing that, what to expect, how to kind of engage with mental health systems, I think can go a long way to helping people both engage in treatment and also stay in treatment.
Yeah, I think to that latter point, each of you really mentioned sort of this role of stigma, particularly it sounds like as it relates to two areas. One is disclosing substance use difficulties in and of itself, but then also maybe some of the social stigma around seeking treatment. And so to that latter point about staying in treatment, I'm wondering how you all see these factors playing out in terms of treatment outcomes, whether it's in treatment retention, however we might define success in treatment, but how do you see some of these things playing out, not just when people arrive, but as they continue on in treatment?
I mean, I feel like it's definitely a kind of a bumpy road, or it can be, and it can be a long road. I think there's some research showing that when it comes to people that are trying to make a change to their alcohol use, that it may take a good 10 years to get to a place of sort of, lasting recovery. And so I tend to work with a population that is pretty severe on both ends of the spectrum in terms of their PTSD symptoms and their substance use. So I see a lot of coming and going, and people kind of, trying and stumbling, and then maybe disappearing for a while and then coming back. We're always hopeful that they will return. And that's also, I think, can lead to embarrassment and shame and difficulty with coming back. But hopefully we kind of set the stage for that is part of the process, and then making it okay to return.
I think one of the other things that I think is important, and obviously like I said, I don't do as much clinical work now, but is the expectation of what to expect from treatment and being realistic about it. I think for a lot of folks, especially if they've not really sought out any formal mental health or substance use treatment or support before, there's kind of the expectation that I'm going to go, they're going to do something, and then I'll come out the other side and I won't have these problems anymore. And I think trying to challenge some of that and thinking that this is something that we'll continue to have to deal with, identifying stressors, kind of navigating different life stresses as they come up, that there might be triggers at different stages that we just have to be aware of and know how to handle, and how that can impact, again, how we navigate our mental health, and being able to not prevent those stresses from happening, but knowing how to handle it when they inevitably come up. And I think that could be a helpful way of kind of reframing it as well, for people in recovery, but also just again, for general mental health, just the expectation that there's going to be shifts, and that's something they'll continue to manage.
I absolutely agree. I think the literature and also just anecdotally, I've seen how big of a difference having social support has made in people actually, coming to treatment and eventually obtaining like their goal, whether that's, complete abstinence or reduction. But I've seen less no-shows in like group settings than I have in individual settings. And as well as, one of the biggest things that I learned when I started doing substance use like treatment as a clinician is just like we have to assess what their home life is like. Because if they're going home and they're trying to reduce their substance use and they're going home and they have other folks around them that are continuing to use substances, it's going to be, pretty difficult to achieve those treatment goals, and how to, do some motivational interviewing, just like how do we get you to a place where you feel safe and feel like you do have that support to achieve whatever substance use reduction goal they have.
The one thing that I want to kind of come back to, I thought was an interesting point that the panel's already brought up, is this issue that essentially a lot of these factors may contribute to not only think about treatment initiation as a one-time thing, that this may have to happen multiple different times with multiple different iterations of receiving care. And so I'm curious if the panel has any thoughts on how do we potentially facilitate the return to services, if that is sort of the expectation, that this is probably not going to be a one-time thing or a one sort of treatment episode situation. How do we potentially facilitate that, in bearing in mind some of the things that you've already mentioned around some of the stigma around the substance use difficulties themselves, and in just being in care itself?
I think it's a challenging balance to strike, because obviously you want to instill hope, right? And you don't want, when someone's finally coming in for treatment to say like, this probably isn't going to work this time. Like but so I do think, though, that part of working, as I'm sure we all know, like working with substance use is sort of planning for, things to go wrong, and having hopefully supports in place or skills in place to manage that. And so I think I try to, again, sort of thread that needle of like, it's great that you're here. Let's give this a really good shot. And also just know that it's not usually a linear path, and and that's okay. Just sort of trying to manage those risks though when they come up.
I appreciate that. So we'll switch gears just a little bit. I'm curious from the panel. We've talked a lot about how people access care, a little bit of experiences once they are receiving care. I'm curious what you all think about if you could change one thing about how providers typically approach treatment with people experiencing this comorbidity of substance use with PTSD or depression. What would you change about that? And why would you change that one thing in particular?
I think that's a really important question, and I am glad to see that. I think some of the sort of conventional wisdom is shifting in recent years, but I would say from my perspective, my hope is that people might sort of really kind of embrace the idea of comorbidity, of these are co-occurring disorders, and we need to treat them in a more integrated way rather than sequentially, which is the traditional wisdom of that someone needs to achieve a certain amount of sobriety before they can address trauma or PTSD symptoms. And unfortunately, there's, a lot of evidence that that doesn't work. And there's been a lot of, negative outcomes for patients when they are kind of told, you need to do this first, as opposed to offering treatment for PTSD at the outset. So that is something that I feel strongly about, that I wish that that could change a bit more.
I think the situation is further complicated by the fact that frequently a person would be sent down the hall for the substance treatment rather than have it take place in the same room, same thing.
Absolutely. And I think at the VA, we wind up doing what is called concurrent treatment, which is, better than the sequential, like, saying you have to do one thing then the other. But you're right, like they're often seeing different providers for different things. I am one person in this role of trying to do integrated care, and there is someone in my role in every VA in the country. But again, that's sort of the exception rather than the norm.
I wholeheartedly agree. And I think some of the work that I've been doing with Project Harmony and some of the other research teams that I work on are really dedicated to these efforts. And so the folks that I work with at the Center of Alcohol and Substance Use Studies and across the country, I think have done a tremendous amount of work to showing what options are there that are really effective for treating co-occurring PTSD and substance use disorders. And also, what works the best? If there's many, positive doors that we can go through, is there any one that, works better than others, and trying to demonstrate that across clinical trials. So I wanted to mention that, but I think also, in addition to expanding integrated services and certainly being able to see one provider that you have rapport with who can really kind of holistically address some of these presenting concerns, I think also working in an interdisciplinary way, really to think about their other social determinants and other just kind of human needs. Because that was something I think that came up when I was doing clinical work too, that it's really difficult for people to focus on substance use treatment or treatment for depression, things like that, if they're food insecure, right? Or if they don't have stable housing, if they don't have enough money to keep utilities going. And so I know, obviously, I think it's difficult to expand the scope of services and to figure out, what is our role in being able to connect people to these different resources. But that's where I think there's both the role of expanding our clinical ability to be able to treat co-occurring disorders, and also work with a broader network of providers or of other resource givers that I think really can help to address multiple needs, while still respecting, obviously, that everyone will have differing areas of expertise and a differing role in providing for that person.
I absolutely agree with what everyone is saying. Like, it would be great if everything was much more integrated than most of the time it is. I guess the only other thing I would say, pretty simplistically, like, I wish there were more providers. I wish there were more providers that were willing, like Dr. Bauer was saying, willing to address these comorbidities, and just had training in, not shying away from like substance use issues. Yeah.
I think that's also a good point. If I can expand on that, I think something I've been working in the area of substance use since graduate school. And so it's, It's what I love to do. And I guess because of that, I've been surprised along the way at how many people don't want to do this work. And that's kind of a, obvious statement, I guess, but I've noticed that in graduate training, beyond, even, unfortunately, sometimes in people's medical records, seeing what other like medical providers, how they might discuss someone's substance use or their medical complications related to it. It's just a reminder that not everyone wants to work with these patients. And that would be great if that could also shift a bit.
All right, I think that's an interesting point. I will admit to the fact that I like to think that I used to be one such provider where, my training is much more in the PTSD treatment, and it's addressing that, what seems like, well, the complication of substance use, and I can't do my normal things because substance use difficulties may be present. So it's a fascinating point across multiple folks that um, that when I posed the question, I was thinking more about what you would change about what providers are doing once somebody is in the room. But this is suggesting that even providers being willing to let somebody into the room to address those multiple concerns is a particular challenge. And I would have to imagine that also links back to um, people's hesitancy to disclose. And even more so if we're talking about multiple instances of treatment, that, well, maybe the last time I disclosed that this didn't go so well for me. And uh, and thinking about even just that role of the way providers approach who they're willing to work with and who they're not. And I would have to imagine that plays into a number of health inequities and a range of public health factors, which sort of leads me to the next question. And I'm curious, so we've already touched on this idea of maybe provider training and making sure providers are comfortable addressing this intersection. But I'm curious what other kinds of urgent public health and even policy implications you see for this field. So what are those, as far as you see it, the most important public health and policy related areas that need to be addressed at this intersection of substance use concerns and comorbidities?
You've stumped us, Trey.
No other public health kinds of implications, which is fine. We do have our first question. I actually think it'd be good to get to this before we move on to some of the other questions. So this comes from one of our attendees here, asked about a context of, it sounds like working in residential rehab, especially with 28-day stays. And so the question is, how do you assess when patients are ready for trauma-focused therapy? And they use the example of EMDR, anticipating other contexts like VA. We're probably talking about things like prolonged exposure, cognitive processing therapy, more recently written exposure therapy. What are the kinds of indicators that you look for, or that I would also expand to, what kind of indicators does the literature suggest that there might be for whether or not somebody is ready for that kind of treatment?
I mean, I would say, and from my clinical experience, like when someone is in a residential program, it is such a great time to offer them PTSD treatment when they are not, I work in an outpatient clinic, and so people are in their lives and they're dealing with kids and work and or financial problems and all those other stressors. And so if someone is in a residential rehab and they're not acutely withdrawing, I think that would be the caveat from my perspective. If someone, needed a detox and needed, to feel a little bit better, before they had the wherewithal to engage in a trauma treatment, that would be a consideration. But otherwise, I think there is literature suggesting that people do well even in early recovery from substance use when they're offered PTSD treatment. And I've certainly worked with many veterans who went to a residential program and started something like EMDR or CPT, and maybe they didn't get all the way through due to the length of the program, but they got a good jump start and then they continued on as an outpatient. So it can work, I think, pretty well.
I think, Trey, to tie this back to your earlier question, which we didn't have any apparent answers. I think adequate funding for treatment would be something on a policy level that really should be acknowledged, because to treat somebody with a roof over their head provides you with so many more degrees of freedom, as Christy suggests. But to be able to afford that is an entirely different matter.
I agree. And I think, going back to that same question, that asking about public health policies, I think is tricky because there's so many things that are really kind of entangled with each other. And so how do you pick out, what to address first in order to create change? I think is difficult. But my mind goes to obviously like addressing social determinants and having, funding for those things, having resources and safety nets for people. But at the same time, I think changing or shifting, I suppose, the way that we think about or conceptualize mental health and substance use risk. Because again, I think it's in many cases like kind of a them problem, or feeling like this affects some people, but it doesn't affect me. And so kind of shifting that idea that there's just, as human beings, we all experience, emotions and stressors and things like that throughout our lives. And so the ways when maybe stressors start to transition into symptoms, and then those, accumulate into a disorder, right? And understanding, how that occurs, and then again, how common it is for people, even to have like sub-threshold types of depression or anxiety. So kind of hand in hand with that, I was like the mental health literacy and awareness of some of these things, and how common and really pervasive they are, I think, across different types of communities. And at the same time, understanding that, again, that there's treatment options available, certainly, but there's a lot of things that folks can do day to day around how do I manage mental health? How do I take care of myself? Specifically in a way that is not expensive, that doesn't require any particular, products or services, things like that. Because I think, some of the things that I have had recommended in my work are, public health awareness campaigns, mental health literacy campaigns, those types of things, especially on social media for reaching young people. But there's also kind of the double-edged sword where then, folks, I think, especially on social media, maybe have misinformation about prevention or symptoms, and then are kind of tying into a specific product where they're selling something. And so for people who, have limited financial means, or who are young adults, I think that can be really challenging. But understanding kind of at its base, what do we mean when we talk about mental health, and how do you take care of that? Because everybody has, mental health and well-being, not just when it's a disorder. So really trying to just kind of understand at a more basic level, like, how do I take care of myself just as a human person? And what are some of the ways that, that works for me compared to other people, especially?
Yeah, I think it's really interesting to recognize social media as a player in the public health landscape, as well as information and disinformation, and in many health related spaces, but especially in this one. I did quickly want to come back to a little bit more directly the audience question from before. We're talking about whether or not somebody's ready, and I'm curious if folks have thoughts on this idea, because at least as a somebody where I do a fair amount of training on PTSD treatment, both receiving it and providing that training, And this question comes up a lot, both in the context of substance use disorders, alcohol use disorders, and just in general. And it's always been my understanding that we're pretty bad at predicting what ready means for trauma-related treatments, and that often we may make assumptions about what that readiness looks like that aren't always borne out by the data. But I'm curious to get the rest of the panelists' thoughts on how would we understand what ready means, whether it's in this 28-day residential context or in others, about whether or how we make that determination about what does readiness look like? How are we even determining that, either from your experience or from your understanding of the data? And I will admit, I will happily be contradicted if you're aware of other perspectives or other data that might suggest, no, there are some ways to think about this and really predict and assess whether or not somebody is ready for the trauma-related aspects of treatment.
I think my first thought about that is I would make a distinction between readiness and willingness. And I have really come around to really focusing more on willingness, because I think you're right. Like, we don't, even when we think we've done the greatest job explaining what these treatments will be like and what is, what it's going to, what's going to be asked of patients to do them. I don't think they really can know until they're in it. But I think willingness, if someone's willing to at least try to approach their traumatic event rather than avoiding it or self-medicating it or what have you, then I'm going to go for it. I will say, with the population that I work with, I have a lot more starts than finishes when it comes to trauma-related treatments such as PE or CPT that we primarily offer in the VA system. But I do a lot of MI when it comes to addressing trauma, just like we do MI related to substance use. So that's, yeah, I'm not sure about readiness, but I, like I say, I've come a lot around to, I talk a lot with people about what they're willing to do.
One thing that comes to mind to me when I think about this that resonates with that, Christy, is the importance of listening to your client and really getting a sense where they're at and trying to meet them where they're at.
Mm. Right. I think that's a good point, because I think these are also clients or patients that are used to people telling them what they need to do or what they should be doing or what they're not doing. And so I do think it goes a long way to be collaborative and to meet them where they're at.
I would also add, especially if one isn't as maybe experienced in providing trauma-informed treatment, like assessing to make sure that this isn't like a me thing. This isn't something that like it's a barrier for me to hear about these traumatic experiences. Because at least for me, outpatient settings, I don't know about the 28-day residential settings, but if a couple of sessions come up and, have passed and, they kind of sort of refer to a trauma or a traumatic event. And I'll mention just like, hey, I noticed that like this is still impacting you day to day, like the thoughts that you're telling me and the stuff that, the behaviors that are problematic for you. They might be related to this. Like, what do you think? So kind of assessing more that willingness that Dr. Capone was saying, and listening to them, because they might just be super avoidant, just like, no, I don't think so, or no, I'm not affected by that. We're not going to be pulling teeth here. But yeah, so like the Dr. Monti was saying, listening to them and listening to see if they're willing, but also making sure that you as a provider, you bring it up, because if you bring it up, you're also saying that you're comfortable with them talking about it during session. And sometimes, especially depending on what the trauma type is, it might be very stigmatizing, and it might be very difficult for them to bring it up, especially if they're not, used to discussing it.
I think that's a good point too, because I work with two teams at our hospital. So I work with the trauma team and the substance use team. And it's just an interesting perspective because I've observed people being uncomfortable in both settings with the other thing. So people in our substance use team might, and are very well intentioned, but they're like, ooh, he brought up this, very difficult traumatic event. I don't know how to deal with that. And so they'll refer the patient, which is fine, but sometimes veterans get the message like, oh, they can't handle that, or oh, I freaked them out, or something like that. And then vice versa, on the trauma side, a lot of times people don't feel like they're out of their depth with substance use and feel like you have to go over there to talk to someone else. And so I do think there's a lot that gets brought up, like you're saying, for the provider, like their own comfort level or their own feelings about things or what have you. It's it's a good point to be self-aware, I think.
Yeah, I'm not surprised that you found that. It's been pretty interesting. And again, I should preface this as someone that has like I cut my teeth providing trauma-focused treatment. Like Trey was my first supervisor. We started with trauma-focused treatment. So for me, I don't ever shy away from it, but I have seen how that's very different depending on one's training and one's comfort level. So just like, not encouraging anyone to practice outside of their scope. But also being mindful and like aware of just like, is this like something, what am I bringing into session? And of course, hopefully we have a team that we can consult with, and get some more perspectives. And I think that's also invaluable as a provider.
I think it's fantastic. We essentially have a full circle moment here where we're again coming back to this point of um, uh, integrating treatment. That it's true that maybe people trained with a trauma focused or sort of depression related treatments that get uncomfortable when there's mention of substance use, but the opposite also happens. Um, so yeah, it's interesting to see that a kind of full circle moment there. Um, I am. Uh, I'll move us on a little bit because I want to make sure we get to some other areas. We do have a couple of questions here from the audience, and for those who have submitted your questions, I'll take a second to review them. If you have questions but you haven't submitted them, please do use the Q&A function, and I will be reviewing it for sure. But in the meantime, one area where we haven't really talked is that we know this comorbidity is extremely common between substance use, PTSD, and maybe depression or other kind of mood concerns. And I'm curious if you all can talk about maybe some of the unique overdose risk that exists at this intersection, or maybe some of the prominent ways that you see this comorbidity contributing to overdose risk.
It's an interesting question. I haven't actually thought about it like that, how this contributes to overdose risk specifically. Although I think for me, one thing that stands out is sometimes people that have experienced trauma and people that are, involved with substance use have a lot of risk-taking behavior. And so I know that clinically I've worked with patients over the years that just took a lot of chances regarding their substance use. I don't know if that's unique to having PTSD as well, but and I have lost veterans to overdose, to accidental fentanyl overdose, and so it's it is a part of this picture, and it's a terrible part of it, but I don't know what the mechanism is, I guess I'd say.
any other thoughts on some of the overdose risks that might exist? I do have a question from the audience that'll tie in a little bit. So I guess I'll go ahead and jump in with that. And if you have other thoughts, for sure jump in with overdose. But one of the questions we got from the audience is essentially having you all speak to what you know about the way that ADHD and that comorbidity may also play into substance use concerns, or at this intersection of things like PTSD, mood concerns, and substance use. So getting it again, that role of ADHD there.
It's a good question because I think it may be a factor in a lot of ways, like maybe even like with the etiology of people's substance use disorders, or I think what we know, I'm not an expert in ADHD, although I've worked with a lot of patients that have ADHD, is that again, the impulsivity, people with ADHD are at risk for substance use, and maybe as a form of self-medication, but also maybe related to impulsivity, difficulty with emotion regulation, and all that. And so there's definitely, and my lens, and I apologize, my lens is very much through the veteran lens. But I know it seems to me, a lot of people that join the military had childhood ADHD and really are sort of seeking out structure. And so it makes sense in that way. And then unfortunately for the folks that I see, then there's exposure to trauma, and then there's substance use. And so can be a very complex clinical picture.
Yeah, I appreciate that. So we're gonna switch gears a little bit again, trying to sort through and take questions from the audience here. And I'll apologize for the person who asked the question. I'm going to modify it a little bit, and sort of tie it back into some of the public health policy implications, especially within the U.S. There's a lot that's shifting, has continued to shift now for several years around legalization of cannabis and the expansion of medical cannabis. And I'm curious what you all see as the role of those sorts of public health policy decisions in these spaces, where we're trying to understand this comorbidity, or where we're working as clinicians to address it. So how does that specific public health policy shift show up in some of the work or the research that you're doing?
I think one of the things that comes up for me is that trying to monitor obviously people's use and misuse, and then whether there's any challenges associated with it. I will say I don't do a ton of cannabis specific research in terms of the kind of biomedical impacts and influences, but I think some of the things that are important to do kind of from a public health perspective are monitoring for unintended consequences, or other factors, things that develop as a result of policy changes. I think sometimes, again, focusing on substance use, misuse, if there are specific changes in that regard in different areas where it's become legalized or it's recreational, but certainly other ways of impacting, kind of the way that we think about alcohol use or other substance use. Are there other consequences around like driving and socializing and all of those types of things that can come out of that? And so I will say, I think the kind of balance that what I'm hoping that we're trying to strike is that looking for the benefits and the ways that this can be used medicinally, or that it can be used to help communities. At the same time trying to minimize the risks, and really making sure that we're kind of being thoughtful and intentional about the policies and then the ways that they are impacting people, and keeping an eye on the ways that those impacts play out over time.
No, I think to add to that, with regard to the increased legalization of cannabis, I think it's a naive clinician who's treating someone for alcohol who doesn't monitor their cannabis use. I think that what's available now is a different potency, but I think also that alcohol and cannabis pretty much go together the same way that tobacco and alcohol went together maybe 20 years ago. They're very commonly co-used, and to treat one and not pay attention to the other, I think, is a missed opportunity.
I will add and say really briefly that I think I've also seen that as it is becoming more accepted, then people vote to legalize, and as it gets legalized, then people feel like it's more acceptable and safe. And so there's a little bit of both in terms of policy and social attitudes. There's kind of a bidirectional relationship. So I absolutely agree. I think monitoring and just asking people about it and trying to do that in a way that doesn't feel stigmatizing. Because I think there's still kind of the role of not wanting to acknowledge cannabis use to providers in some cases.
No, I would just add that I think the jury, like this is maybe a case of policy or laws moving quicker than the research, like, because I think the jury is still out in terms of how helpful or not cannabis is for PTSD. I know that there have been some studies that are maybe ongoing. I'm not, and people certainly correct me if there are results out there, but I think there's been a lot of hope from patients that this would be, helpful or medicinal for treating PTSD. And I clinically do not see a lot of evidence for that. Aside from the only thing I would say, the exception to that is maybe for sleep. But as far as, as clinicians working with PTSD, we're trying to get people to get out there and back into their lives. And I haven't seen any life-changing effects of cannabis. And I work with people using a lot of cannabis. So that's just my lens.
Yeah, I appreciate that, and especially this notion that the policy changes might be outpacing some of the research as often happens. And yeah, that's my understanding as well. I will move us on. We probably have time for one more audience question after this. We'll see how long it takes. We've got about 5 or 6 minutes left on the panel. And so the last one that we have takes us back a little bit to some of the treatment related process things, and specifically asking about how you approach somebody, a patient who regresses. And in this instance, if this person could maybe type in some clarification in the Q&A. I'm guessing by regresses, that means using more, maybe they obtained some period of abstinence and used whatever the substance might have been again. That's not clear in the question now. So for whoever wrote that, please go ahead and if you could clarify, but I'll turn this over to the panel about how do you approach that when somebody maybe has made some progress in reducing their substance use, risk use, or even achieves abstinence, and there is some regression. How do you handle that?
I think again, what Dr. Monti had said about just meeting people where they're at, like that is, and also recognizing that is a part of this process of recovery. And so I think I would, really be glad that they talked about it, that they came back and didn't just disappear. If that was the case, if someone came in and said, hey, I wound up using, or I went back to heavy drinking, and also, spending time doing kind of a functional analysis of like what was going on, that maybe led up to that, especially if they had been substance free for a while and then they returned to using it. I think there's a lot of place for exploration and Yeah. And, I mean, obviously it would be ideal to come from a place of non-judgment and just being curious, about what was going on and how they want to move forward, and sort of partnering with them on that.
Other thoughts? And I'm still waiting on the attendee to clarify or potentially clarify if that's what they were meaning to ask, but other thoughts on how you might handle that. And I'm thinking especially given the theme of this panel, but also knowing some of the specific things that come up often for people who are experiencing PTSD and how they might respond when that kind of regression occurs. So I can maybe add, what do you see as particularly challenging or as unique features when that occurs, and other thoughts on how some of our other panelists might handle that situation.
I think it speaks to the need to outline a sort of conceptual framework with the individual sort of upfront, so that when they lapse, they don't see it as a failure. It's not a moral failing, but rather a missed opportunity to learn or to practice coping skills that you may or may not have even gotten to at that point. So again, I think it's important to lay out the framework from the outset in therapy so that you have that to refer back to when this kind of thing happens. And it's likely to happen, as we've been discussing here. This is a relapsing disorder that we're talking about. Particularly in the context of PTSD.
I agree, and I think just trying to lead with compassion and trying to instill hope that this is one time we can continue to move forward. It's not it's not the end, and really understanding that other ways that what Dr. Monti just said. Can we introduce new coping strategies, or can we come back to the ones that we've already talked about that maybe we could reframe on how to use them, when to use them, what does it look like? And then also just finding ways, as my co-panelists have talked about, in exploring home environment, exploring all of the things that might have made an impact in this person's return to use. And if there's anything specifically different that we might want to change about treatment planning and how we might move forward. Or if it's more just, this is something that happened and we're going to continue to kind of work through, the same plan, the same goals maybe that the person had before.
Yeah, I appreciate that. And we are getting to time to wrap up. So I want to thank our panelists. Thank you all for being here and putting up with my questions for the day. Again, thank the audience members for being here, and especially everyone who jumped in and asked your questions. It's very much appreciated to get that interaction, especially in this kind of environment where we can't see you and have that kind of interaction that we might otherwise have. So thank you very much for attending and being willing to participate. And I believe we will be moving on in the programming for our symposium today. Thanks again.